This is the third lecture in pediatric endocrinology on bone metabolism, adrenal function, water balance and thyroid disorders. My name is Dr. Indy Banerjee. I'm a consultant in pediatric endocrinology at the Royal Manchester Children's Hospital and Alder Hey Children's Hospital. The learning objectives of this lecture are to review aspects of bone metabolism, recognizing that adrenal insufficiency is serious. We will investigate some aspects of water balance and the common abnormalities, the management of congenital hypothyroidism, and recognizing thyrotoxicosis in children. Let us examine the first question. Which of the following is true about 1,25-dihydroxy vitamin D3? A. Is it produced by 25-hydroxylation in the kidney? B. It stimulates calcium and phosphate absorption in the gut. C. Production is stimulated by hypophosphatemia. D. Plasma concentrations are elevated in chronic renal failure. And E. Induces proliferation of tumours. The answers are B and C. Vitamin D, as we will see in the next slide, is hydroxylated in the 1-alpha position by 1-alpha hydroxylase in the kidney. Vitamin D enhances calcium and phosphate absorption in the gut. Production is stimulated by low levels of phosphate. Plasma concentrations of PTH are elevated in chronic renal failure. And more recently, we understand there are other roles for vitamin D apart from bone metabolism. In this slide, vitamin D is made by the activation of sunlight. Ultraviolet B radiation on the skin converts 7-dehydrocholesterol into vitamin D. Vitamin D can also be from dietary sources which are absorbed through the intestine and gets into the circulation. In the liver there is 25-hydroxylation, and in the kidney there is 1-alpha hydroxylation, leading to the active form of vitamin D, which is 1-alpha 25-hydroxy D3. This active form of vitamin D has various effects on the bone and the intestine, but also has effects on immune function and tumor proliferation. In the bone microenvironment, there are osteoblasts and osteoclasts which cross-communicate, and the interplay of these cells lead to a balance of calcium in the blood. This is a slide of the effects of hypocalcemia. When calcium levels dip, parathyroid hormone levels go up, which in turn activate 1-alpha hydroxylation of vitamin D, which in turn will lead to further absorption of calcium in the diet, thereby stabilizing plasma calcium. PTH can also reduce renal excretion and increase renal phosphate excretion, both having an effect to increase the plasma calcium. On the bone, PTH can cause bone resorption, again leading to an increased plasma calcium level. Vitamin D deficiency is not uncommon, and in the UK is related to sunlight exposure. A number of Asian children become vitamin D deficient as they are not exposed to adequate levels of sunlight. Maternal vitamin D deficiency can also predispose to neonatal hypocalcemia. In older children, you may see rickets. The treatment of vitamin D deficient rickets is with either cholecalciferol or ergocalciferol, and the aim is to keep the serum calcium level in the low normal range between 2.0 to 2.2 millimoles per liter. This X-ray shows a child with rickets. The ends of the long bones are rather wide. And if you note the epiphyses, they are frayed and stippled. Let us now examine this extended matching question. On your left-hand side is a list. On your right-hand side is the first question. A 1-year-old Asian boy is investigated for anemia. His serum calcium is 2.1 millimole per litre, phosphate 1.0 millimoles per litre, and alkaline phosphatase high with high PTH. What is the most likely diagnosis? And the answer is vitamin D deficiency. The serum calcium is on the low side, as is the phosphate. The alkaline phosphatase is high, indicating bone turnover, and so is the serum PTH. In this child, the vitamin D levels were very low. We now come to the next part of the same question. A 2-month-old infant presents with hypocalcemic seizures. Calcium is low at 1 millimole per litre. Note the phosphate is on the higher side, and so is the PTH. What is the most likely diagnosis? And the answer in this case is pseudohypoparathyroidism. The PTH is high, but clearly ineffective, suggesting PTH resistance, leading to hypocalcemia. Let us now move our attention to an adrenal condition. In this case, a 13-year-old girl who's been missing school for tiredness. She appears to have a generous holiday tan. A blood sample shows that her serum sodium is low, potassium is slightly high, her urea indicates dehydration, and her thyroid function is normal. What is the most likely diagnosis? In this list, this is Addison's disease. This is a typical presentation of a child with adrenal insufficiency in adolescence, secondary to autoantibodies. This is a slide of a child with mucosal pigmentation in Addison's disease. Pigmentation occurs because of high levels of ACTH. ACTH and melanocyte stimulating hormone, MSH, are similar in nature and cause pigmentation in the skin, typically in the palmar creases and in the mucosal membranes on the tongue or in the inner aspects of the gums or lips. There are several causes for adrenal insufficiency in childhood. In the earlier years, congenital adrenal hyperplasia, or rarely hypoplasia, may be possible. In older children, autoimmune causes such as Addison's disease are possible. In all children with Addison's disease, do consider the possibility of other autoimmune endocrinopathy such as hypothyroidism or possibly type 1 diabetes in association. Rarer causes of adrenal insufficiency include adrenal leukodystrophy and associations with achalasia and alacrima, the so-called AAS or Aladdin syndrome. Rarely, infections such as meningococcal meningitis or septicemia and adrenal hemorrhages may also cause adrenal insufficiency. In some children, the cause of adrenal insufficiency is central in either the pituitary or hypothalamic areas, causing central adrenal insufficiency. Let us now examine this question on a 16-year-old girl with secondary amenorrhea for the last 9 months. Her weight is rather low at 36 kilograms. She's slim and tall at 178 centimeters in height. Skin is dry and covered in lanugo hair. Her free thyroxine levels are normal. She's mildly anemic with a reduced white cell count and a platelet count. What is the likely diagnosis? Addison's disease, HIV, occult carcinoma, hypothyroidism, or anorexia nervosa. And this is a typical description for a child with anorexia nervosa. just be aware that there might be phenotypic overlaps between adrenal insufficiency in Addison's disease and anorexia nervosa. If in doubt, it would be wise to exclude adrenal sufficiency by performing a synaxin test. Let us now move on to water balance. In this cartoon, you can see the anatomical connections between the hypothalamus and the posterior pituitary. The posterior pituitary secretes arginine vasopressin, or AVP, which acts on the renal tubules, particularly the collecting tubules. In this cartoon, you can see that AVP acts on the nephron to induce signals which then have an effect on molecules called aquaporins. Aquaporins mediate water transport in the renal nephrons. Water balance is controlled by arginine vasopressin, which acts on the kidneys, but also by thirst, regulated in the hypothalamus. There is a linear relationship between plasma AVP and plasma osmolality. However, between urine osmolality and plasma AVP, the relationship is not always linear and plateaus off at a certain concentration of AVP. This is a slide of plasma osmolality on the x-axis and plasma AVP on the y-axis. The yellow area is normal. Those children with values outside the yellow area are abnormal, either nephrogenic or cranial diabetes insipidus. In both conditions, either nephrogenic or central diabetes insipidus, there is polyuria and polydipsia. How do you define polyuria? It is the passage of large volumes of dilute urine. In practical terms, if a child passes more than 4 mils per kilo per hour, that would signify polyuria. However, please note that in newborn babies and infants in the earlier months, passing 4 to 6 mils per kilo per hour may be within normal limits. Cranial diabetes insipidus is due to inadequate production of AVP. This may be due to cerebral malformations such as septo-optic dysplasia. There may be acquired causes such as craniopharyngioma, histiocytosis. Rarely, there might be autosomal dominant forms or associations with conditions such as the diabetes mellitus diabetes insipidus association, or DID mode. On the other hand, nephrogenic diabetes insipidus is due to renal resistance to AVP. Renal disorders such as nephrocalcinosis and chronic renal failure may cause nephrogenic DI. There might be mutations in the vasopressin receptor or V2 receptor genes, which are most commonly X-linked and therefore occur mostly in males. There may be mutations in the aquaporin genes, which are usually autosomal recessive. In children, particularly toddlers, primary polydipsia may be a cause for polyuria. In toddlers, drinking is a habit, and they may take excess juice as a means of satisfying their hunger. In these cases, excess fluid intake may suppress AVP. In most cases, serum sodium is normal, however, plasma osmolality may be low. To investigate polyuria, you would like to stop excess juice drinking and ask the parents to maintain a fluid diary. An early morning osmolality in the urine and serum may be useful. In cranial diabetes, if the plasma osmolality is unusually high, greater than 295 milliosmoles per kilogram, and if the urine osmolality is low, less than 750 milliosmoles per kilogram, the diagnosis may be considered. However, the diagnosis is not always straightforward and may need specialized investigations such as a water deprivation test. To do a water deprivation test, you would have to admit the child and measure urine osmolality and serum sodium or serum osmolality with a period of water deprivation. At the end of the test, you would want to give a test dose of desmopressin. In children with cranial diabetes insipidus, the child will respond to the test dose and stop passing excess urine. In nephrogenic DI, there should be no response or a poor response. An MR scan of the pituitary and hypothalamus may be useful in cranial diabetes insipidus. On the top left panel is a picture of the normal pituitary with the front of the anterior pituitary in a different texture from the posterior bright spot. In panel B, you can see that the posterior bright spot is absent. In panel C, the pituitary stalk is thickened. In panel D, the proximal part of the pituitary stalk is rather thick, which intensifies further on administration of a contrast medium. In rare cases, such as this family with AVP neurophysin 2 mutation, the cause of polyuria may be genetic and isolated DI may occur. Let us now examine a water deprivation test question. This is an 8-month-old child who is not gaining weight adequately and undergoes a water deprivation test with the following observations. What is the most likely diagnosis? Are these normal results? Does the child have primary polydipsia, water intoxication, cranial diabetes insipidus, or nephrogenic diabetes insipidus? The answer is nephrogenic diabetes insipidus. You can see during the period of water deprivation, the urine osmolality remains the same, and after a test dose of desmopressin or the synthetic form of AVP, the urine osmolality does not improve significantly. The serum sodium has been climbing through the period of water deprivation and does not return to normal after the administration of DDAVP. Let us now examine another scenario. This is a 3-year-old child with excessive drinking of juice, 3 liters per day, who undergoes a water deprivation test and has the following observations. What is the most likely diagnosis? Normal results, primary polydipsia, water intoxication, cranial diabetes, or nephrogenic diabetes. And the answer is primary polydipsia. As you will see, that weight does not change significantly. During the test, the urine osmolality is somewhat lower than expected. However, the serum sodium, and therefore the serum osmolality, is not abnormal. The child responds to a test dose of DDAVP rather well. Sometimes the difference between primary polydipsia and partial cranial DI is not very easy. Let us now examine thyroid function. This is a female baby born at term with a TSH of 90 millunits per litre, which is high. Levels of up to 5 are normal. Which additional finding is most likely to suggest that congenital hypothyroidism is due to a Mendelian inherited condition? This is a best of 5 question. Ethnic origin from the Indian subcontinent, goiter examination, free thyroxine level 9 picomoles per litre, and anti-thyroid antibodies negative in the baby or anti-thyroid antibodies negative in the mother. And the answer is a goiter examination. A goiter suggests that the thyroid gland is present, but the biochemical pathways are inactive. A free thyroxine which is low does not differentiate from dysharmonogenesis from a dysplastic thyroid gland. Autoantibodies in the baby and the mother are useful if there is passage of autoantibodies to the baby, therefore destroying the thyroid gland. They're not useful to determine Mendelian inherited thyroid disease. This is a picture of a child with congenital hypothyroidism who has not been treated, with rather coarse facial appearance, protruding tongue and a hoarse cry. Most children with congenital hypothyroidism are detected on the neonatal Guthrie screening card and should not have the sequelae of poor treatment or no treatment. You can classify congenital hypothyroidism in those with goiter, which is dysharmonogenesis, or those without a goiter. The most common cause of those without a goiter is either dysplasia or dysgenesis. Rarely, hypothalamic or pituitary defects, i.e. central defects, may cause congenital hypothyroidism. In this case, serum TSH levels may be low or normal. This is a thyroid radioactive iodine scan showing uptake of iodine into the thyroid, which appears as a butterfly-shaped structure. If the gland is present or large, as in dysharmonogenesis, this will show up. If the gland is small or absent, as in dysplasia, the image will not be present. In some children, there may be an ectopic thyroid gland in an unusual position. This child has an ectopic thyroid gland in the lingual area at the back of the tongue. The thyroid gland usually starts developing at this position and comes down in embryonic life. Congenital hypothyroidism should be treated as quickly as possible. In some cases, serum TSH levels are not particularly high and are borderline. If so, we should err on the side of caution and start treatment. Thyroxine is very important on the developing brain, and parents should be aware of this, and compliance should be stressed. In some cases, you may note that on follow-up, serum TSH levels are high, suggesting inadequate control. However, the free thyroxine levels may be normal, and this is a typical picture of a child with non-compliance. This is a perchlorate discharge test, which is usually done after 2 years of age. On the right-hand picture, you have administration of perchlorate, which does not lead to a drop in the activity of iodine in the thyroid gland. However, on the left-hand panel, there is a significant reduction in thyroid iodine activity following perchlorate injection, and this signifies a defect in organification in the thyroid gland. Let us now examine this question. A rather tall 5-year-old boy presents with diarrhea and not gaining adequate weight. He is described as fidgety and finds it difficult to sleep. His mother says handwriting has deteriorated considerably over the past few weeks. What do you think should help the diagnosis? The answer is a free thyroxine and a T3 level. This child has hyperthyroidism. The growth chart shows increased height, which is often seen with hyperthyroidism. After treatment, the height gain stabilizes. The diagnosis is made not on the TSH levels, which is suppressed, but on the free thyroxine and T3 concentrations. Celiac disease usually is not associated with increased height gain, and a sweat test would be diagnostic of cystic fibrosis. Thyrotoxicosis is not a particularly common condition in childhood. However, autoimmune causes are relatively common within this domain. In children, the disease is more aggressive than in adults. Do consider other autoimmune conditions in association, particularly Addison's disease. Treatment of thyrotoxicosis as a first line is with carbimazole in the UK. In a proportion, children will need definitive treatment in the form of total thyroidectomy or radioiodine treatment. Usually, medical treatment is started. A period of about 2 years is given for the child to show any signs of remission. If not, definitive treatment may be advocated. The key learning points of this lecture, therefore, are vitamin D deficiency is relatively common and needs to be investigated, particularly in Asian children. Diabetes insipidus can have several forms: cranial, nephrogenic. Cranial diabetes insipidus is rare in isolation. Nephrogenic diabetes insipidus may present with failure to thrive and needs to be investigated with a water deprivation test. Congenital hypothyroidism needs to be promptly investigated and treated with thyroxine to prevent mental deficits and preserve learning ability. Thyrotoxicosis is rare in children, but may be considered in those children with weight loss and restlessness.